Hello and welcome back. Today I'm joined by very special guest, Dr. Christy Sutton. Christy, welcome.
Thank you so much for having me.
You have such an interesting work history. Like you are a chiropractic doctor, yet you have this passion for iron and hemochromatosis. How did that come about?
I think I'm just kind of always trying to learn more and always asking why is that happening and trying to figure out, not only why is it happening, but how can we make this better naturally or at least with the least possible harm. And I think that just has kind of carried through a large part of my life. And for better or worse, personally, I've struggled with a lot of health problems, either myself or loved ones. And then, I am a chiropractor and I do traditional chiropractic treatment, but I also do, more holistic type stuff as well. And so I get a lot of interesting cases and people that they just want to be healthier and they don't really care, what the initials are after my name. They just want to get to the bottom, the root cause, whatever you want to call it. And that's kind of where my uh, brain tends to want to go to and kind of figure out, follow the thread like as much as possible to really figure it out as deep as possible.
I love that that's becoming more and more common these days. Less and less people are looking for a band aid to stick on top of the problem, and more people are asking, why? What else could it be? What else is possible? What else is possible? And digging, and doing the work. And for me as a practitioner, I always start with minerals. Minerals are key building blocks, but we don't want too much. We don't want too little. Just like Goldilocks, we want just
Mhm.
right, just in the middle. And iron is a perfect
It
example of
is.
this. So I'm so happy to have you here today. So what are some of the symptoms that you've noticed with your patient group that would make you start considering, is iron a problem?
Um, well, because like you said, it could be both too high or too low. The symptoms vary greatly. And interestingly enough, some of the same symptoms of low iron can carry on to high iron as well, like fatigue. Low iron and high iron can cause fatigue. Um, Low iron and high iron can create a lot of cardiovascular stress, which can create, increased heart rate, decreased heart rate variability. Um, I have really a pretty solid mindset now that everybody just needs to get very thorough lab testing, because it's on for iron every year, possibly multiple times a year, depending on the person, because it's not very expensive and because it can create so many issues and the symptoms often get missed, not just with low iron, but also with high iron. And I talk about both in the book, and I talk about how, you know, not just high iron is dangerous, but low iron, a lot of people don't realize, like, if you're low in iron, that could cause ADHD. And a lot of kids that have ADHD have undiagnosed low iron. Women that are pregnant, for example, if they don't have enough iron during the first 30 weeks of their pregnancy, then their children are more likely to have autism, ADHD, and a significantly lower IQ. So I just feel like we kind of have to get past the symptom piece, and it's a basic enough lab to draw on people. It's not like I'm asking for some like obscure, you know, lab that you can't necessarily get. Like, these are labs that every clinician can order. A lot of people can order them on themselves for not very much money. So, the symptoms can be anything, literally.
So what I would add to that is, say, for example, you're doing a puzzle. You don't just want one piece to see the picture. You need multiple pieces to get a better idea of what's going on. And if you just go to your doctor and ask to get iron checked, iron is only one piece of the puzzle. You really need to do a complete iron panel and a full blood count or a complete blood count, depending on which part of the world you're living in, so that you have a greater understanding. Like it's the same with so many things like thyroid. Quite often they just do TSH, but it's only one piece of the puzzle. You need more pieces of the puzzle to get a more complete view of the picture. So I just wanted to plant that in there so that women are mindful that when you're going to ask for this testing, to actually ask for a complete iron panel, including ferritin, and not just serum iron, because it's not really giving you enough information.
Yeah, that's a really good point. And this is one of my biggest pet peeves is oftentimes people, they will not get comprehensive labs. They won't get a full iron panel. And so what's in a full iron panel, and I think people need to know this because I think that really people have to, they can't just go and say to their doctor, please order all the iron tests, because their doctor might just think, oh, that's serum iron or ferritin. What they really need to do is they need to name them out, like make sure you order all of these tests. And the tests that they need to ask for, bare minimum, are serum iron, TIBC, UIBC, iron saturation, and ferritin. And then, of course, you always need a CBC. That's what we call it here, a complete blood count. You might call it something else there.
Full blood count. So
Full
it's just
blood
an
count.
F instead of a
Yeah.
C.
Yeah, to get the red blood cells, hemoglobin, hematocrit, white blood cells. Yeah. So, bare minimum, these are easy and expensive labs to order, but unfortunately, often patients will only get an iron, or maybe if they're lucky, they might get a ferritin too. So you need all of the labs. And I think the analogy to the thyroid is a really good one. And I think that as people, learn more about iron, they're going to realize, oh, there's a lot of undiagnosed, both low and high iron issues that were just not properly diagnosed because their doctors were not ordering the full labs. And then on top of that, there's some simple genes that everybody needs to know if they have, like the hemochromatosis genes, which can cause you to be high in iron
Mm.
because you absorb too much iron.
So something we haven't discussed is that you have a wonderful book called The Iron Curse. And I was reading through it in preparation for today, and I discovered something that I had never known. So thank you for that. And that was the carrier myth. So could you just explain to the listeners what the carrier myth is?
Sure. Yeah, I'd love to. Yeah. So to answer your question, I need to first start with a short story. I originally kind of unintentionally learned a lot about hemochromatosis because I was writing my first book, which included a chapter on the hemochromatosis genes, just me learning about it, no big deal. And then I realized my husband had undiagnosed hereditary hemochromatosis, high iron. And then I walked him through all of the steps of getting him diagnosed, I learned a lot. It was not necessarily the best experience, but I learned a lot from it. And I took what I learned and I layered it onto what I was already doing in my practice at that time. And what I had fortunately been pretty good about doing throughout my whole practice is looking at iron labs in people. But and if I would see, I would often see people with low iron. I think I had a much lower threshold for that. Occasionally I'd see somebody with like a high iron and I'd say, oh, donate blood or something like that. But it was once I learned about those genes and I, walked through the steps of getting my husband officially diagnosed and realized what the layperson's up against. So I layered all of that knowledge of always looking at the genes too, if I could, and, the technical way to diagnose it. And I realized that there's a lot of people out there that are undiagnosed with hereditary hemochromatosis, which means that they have high iron saturation, have high ferritin, iron's destroying their health, and it's because they have this gene where they absorb too much iron. It's just a genetic issue. It doesn't happen for everybody. that has this gene, but it happens for a lot of people that have this gene because over 30% of the population has this gene. So because so many people have this gene, it doesn't have to affect everybody. It just has to affect, part of them. And so to circle back away to the carrier myth, the carrier myth is basically saying that you can still develop hereditary hemochromatosis if you just have one gene. And I kind of fumbled into that because my husband was diagnosed with only having one of those genes. And as I looked through patients' histories and their labs and their genes, most of the people I was seeing with hemochromatosis only had one gene. And occasionally I would see people with two genes, and they were more likely to have hemochromatosis because having two genes is a higher risk than having one. But there's this myth that if you have one, you're safe. And that's a myth. Um, a large number of people with just one gene do develop hemochromatosis. It tends to be, women that are postmenopausal or just men throughout basically their whole life. The risk increases as they get older. They're a higher risk because they're not menstruating, childbirth, all that. And then actually there is a large undiagnosed population in children too. But those people tend to have more like two genes. But as people get older, and their iron stores increase often, especially men and then postmenopausal women, the risk goes up and one gene is really sufficient enough. And most of the people who have a hemochromatosis gene only have one gene. So they're quote unquote carriers, but they're not really carriers because in order to truly be a carrier for a disease, you would only carry the risk allele but have no possible side effects, health problems from that risk allele. And the only risk that was associated with that gene would be that you might have a child with somebody else that's a carrier, and then they would get two, and then they would have the disease. But that's just not how it works out with hemochromatosis and many other diseases, but especially hemochromatosis because this disease is as much about your environmental factors as it is about your genes. It's about how much iron are you eating? Are you a vegan? Are you a vegetarian? Do you have malabsorption issues? Do you have a GI bleed? Do you have heavy menstrual cycles? There's multifactorial reasons for this is as much an epigenetic disease as it is a genetic disease. So the carrier myth is something that, I coined that term. I'm pretty sure I've never heard anywhere else. And I have a whole chapter on it. And then, I even talk about how there's other diseases like Wilson's disease and hemophilia, where like the research shows that these people, they might not have hemophilia or Wilson's disease, these genetic diseases, but they still just with one risk allele, just one, not two, have some health problems. And that creates an issue where a lot of these people get kind of dismissed and mismanaged. And we need to basically end these myths because it's causing a lot of people to deal with a lot of health problems that would be easily avoided.
I read somewhere in your book that on average it's about 10 years to be diagnosed with hemochromatosis. Is that
Yeah,
correct?
10 years, 3 doctors, and only about 10 to 20% of the population that is diagnosed gets only about 10%, 10 or 20% of the population that has hereditary hemochromatosis gets diagnosed. And that's just looking at hereditary hemochromatosis. That's not even including the statistics for non-hereditary hemochromatosis. So there's a huge population. And then there's also, there's a third hemochromatosis gene that is not even being really looked at. Like when my husband went to the hematologist, they only ran the two main hemochromatosis genes, but like there's another one that only mildly increases the risk for hemochromatosis, and but it's not being looked at. So it's one of those things where if you're not collecting data on something, it's really hard to know what's going on. So I added that third gene to the genetic detoxification report that I created, that if you've done 23andMe, you can get your report and it'll give you all three hemochromatosis genes. And I think that's really important. And I just recently did that, but I've already discovered people that have one of those genes and they, developed hemochromatosis. So it's important.
I guess we should look at, well, what are some of the concerns of hemochromatosis? Why is it worrisome in the first place, but also why would waiting 10 years to diagnosis be a concern?
Yeah, that's a really good question. Um, so it's funny, sometimes like I start talking about the nitty-gritty, but it's like we kind of passed over what does it do to the body. So hemochromatosis, it is really this kind of like sneaky, pernicious disease that it kind of like comes on very slowly, and the symptoms people often don't realize, it's like being a frog in a water that's boiling. You kind of just slowly don't feel as good. Slowly, you fatigue, cardiovascular health goes down, exercise is harder. But as far as what it does under the surface is, when you have too much iron, then it will start storing, because iron is this really precious mineral for the body. And through evolution, the body has evolved to be very efficient to keep as much iron as possible. And so we really are designed to not lose very much iron on a daily basis, other than females really through like menstruation and childbirth. Um, and that's part of why iron is tightly regulated, so that you don't really lose it. And so we have these storage pools to kind of like save it for the rainy day. And one of the big storage pools is the liver. And so often when you have high iron, the liver will kind of be like the first collateral damage. And maybe you'll see high liver enzymes on labs, maybe it'll cause fatty liver. Or maybe you just won't get diagnosed and you'll get liver cancer, 10 or 20 or 30 years down the road, which is a reality for a lot of these people. There's a 200 times increased risk for liver cancer with people who have hereditary hemochromatosis. So it's significant. So, first the liver kind of gets destroyed. And then as the liver gets filled up with iron, then the iron starts spilling over, and then it can go to other parts of the body. And there's specific parts of the body that it really likes to go to. Just because those parts kind of have more of an affinity for it. And so it likes to go to the pancreas. And when it goes to the pancreas, it will cause insulin resistance, it'll cause diabetes, it can destroy the insulin producing cells. You could get type 1 or type 2 diabetes with it. Actually, there's a term, bronze diabetes, for hemochromatosis patients, because the extra iron can cause this kind of bronzing discoloration of the skin combined with diabetes. And so, years before we had all these extra labs to diagnose everything, one of the ways to diagnose it was, oh, you have bronze diabetes, you're discolored, and you have diabetes, which at that point in time was like the doctors were drinking urine and it was sweet. That's how they diagnosed it. That's disgusting, but that's how they did it. So it destroys the pancreas. It likes to go to the heart and destroy, the heart, cause cardiovascular disease, increase the risk for not just the heart, but the whole vascular system. So you're going to have more vascular inflammation, atherosclerosis, clotting risk, failure, arrhythmia, serious cardiovascular issues. It likes to go to the gonads. the testes, the ovaries, and destroy those. And so you'll see a lot of infertility issues, where people will have infertility issues, increased risk for ovarian cancer, testicular cancer, hormonal type issues. It likes to go to the brain and destroy, cause Alzheimer's, bipolar disease, depression, Parkinson's. It likes to go to the anterior pituitary gland. It doesn't really like to go to the posterior pituitary gland, but it likes to go to the anterior pituitary gland, which is this, small but extremely important part of the brain that controls so many hormones. It will, so these people, get this extra iron in the pituitary gland, and they'll often have issues where maybe they're not growing as well, especially if it's a child with high iron, because the growth hormone's getting shut down, or infertility issues because they're not making enough of the sex hormones, estrogen, progesterone, testosterone, or maybe even thyroid issues because it'll cause less TSH production. It can also go to the thyroid and actually damage the thyroid, but by damaging the the pituitary gland, it will suppress often TSH and increase the risk for Hashimoto's and other thyroid issues. And it'll also affect the ACTH, which is the adrenal cortico-stimulating hormone, which often it will create like adrenal issues where you're not secreting as much ACTH. Ironically, my husband, who had undiagnosed hereditary hemochromatosis for a fair amount of time, I don't know exactly how long, but I'm just pretty sure it was a while. He developed a pituitary tumor in the anterior pituitary gland that caused him to secrete too much ACTH, which caused him to have too much cortisol, Cushing's. And I credit him having hemochromatosis as a driving factor for that. I have no way of proving that. I could be totally wrong, but I just think that, if you have a disease that creates a lot of oxidative stress and damage in a specific part of the body, and then later you're diagnosed with a tumor in that part of the body, it's suspect to me.
Mm.
So,
Yeah. Um, Two things I wanted to add to what you were saying. Recently, in podcast episode 169, I did on overload in iron overload in menopause. We looked specifically at how iron affects the hormones, and there was a really beautiful research trial looking at elevated iron increasing hot flushes. And I think that's due to the anterior pituitary actually increasing sex hormone binding globulin, lowering your estrogen levels. But if you want to know more about that, head back to episode 169 and you'll hear about that. And the other thing I always think of when I'm looking at high iron is the bones. I see like your
mhm,
iron rusts outside the body. So iron inside, I see it rusting the bones. And like as you'd see in a rusty gate, like be corrosive. So it can contribute to osteoporosis in the bones. Like you might get a
mhm,
creaky gait, you might have osteoarthritis and creaky bones. So it really is a systemic whole
mhm,
body issue that can be overlooked and often misdiagnosed as other things. So it certainly is something that I always ask my women to at least check annually, and if it's a problem, we do more regularly. But if you've never had an iron test, hopefully this is the motivation to go
mhm.
out and get all the tests that Dr. Christie has recommended earlier on.
And
You
joint pain. It can create a lot of joint pain too. Yeah,
yeah.
and that gets undiagnosed and misdiagnosed all the time. Because I'm a chiropractor, so many people come to me for joint pain, and then they kind of realize, like, oh, you know a lot of other things. What else can you help me with? Um, and often it's like, your joint pain's not going to go away until you get that iron under control. Especially, it seems like knee pain is a really common joint to be affected by high iron.
Mm. And a lot of women just put it down to, well, I'm just getting older. I'm like, I'm sorry,
Hmm.
no. Let's dig
Right.
deeper and let's see if there's like an issue that we can correct or something that we can work on and change so that you're getting a deeper level improvement. Not a fan of the band-aid effect. But anyway.
Yeah, the I'm getting older thing, I sometimes I think while age no doubt has an effect on one's health and that's undeniable, I think also there's an element of just um I'm not trying to say anything bad about anybody, but sometimes I think it's kind of like a lazy diagnostician. I don't really want to work on getting to the bottom of the problem, so I'm just going to blame it on getting older. Because so often, I'll see people that, well, my doctor said that this is happening because I'm getting older, and it's like, well, I can't turn back time, but if I get this problem to go away, then it's not because of age. Like, and often the problems go away. And so it wasn't age, it was just a lack of, spending time to figure out why the problem was happening.
Mm. So we've discussed, how you can test, what sort of harm can be done, but what happens when you've had your testing, you've gone right, whether it's hereditary or acquired hemochromatosis, what can I do now?
Yeah, there's a lot of options. Um, So assuming that you have figured out that, okay, you have high iron, and then if you do have high iron, then you need to figure out, do you have the hemochromatosis genes, assuming you figured that out. Because regardless of having high iron because of a gene or not, like it needs to be lowered. But if it's high because you have a gene, then that means that this could potentially be like a chronic issue that you can't just go like donate blood and you're good forever. This could be a chronic issue that keeps creeping up on you, and you really need to have somebody to watch you for the rest of your life that knows what they're doing. So, okay, so assuming that those things have been figured out and accounted for, then if you um if you go to a doctor that is really the best at treating this, technically that would be in America a hematologist. Um, Gastroenterologists, cardiologists, primary care doctors can and should be able to treat. But there's clearly an issue going on because most people are not getting diagnosed and treated. And it's taking a long time. So I think, we need to go beyond just wait till your doctor diagnoses you and go to the hematologist because that system's failing. So once you get your labs and you have high iron, you want to try to get in with one of these doctors. In the meantime, if you can't, then, of course, donating blood is an option if you can donate blood. Many people cannot donate blood because maybe they've had an infection, tick-borne disease like Lyme, or traveled to somewhere with malaria. So if you can't donate blood, but you're still healthy enough to have blood removed, then you can get a therapeutic blood removal form from your doctor, and then you can go to a blood donation center and have blood removed. So that's one way. Now, some people cannot have blood removed because they're maybe at risk for acute cardiovascular failure, and just the act of losing blood could send them into cardiac arrest. Or more often, what happens is a lot of people develop high iron and low red blood cells or low hemoglobin, and then they can't donate blood because they have what's called iron loading anemia, which is where you have high, and there's a lot of different reasons for this. There's numerous, but they have high iron but are anemic because they don't have enough healthy red blood cells or hemoglobin. And so if one was to go to like a hematologist, they could give them some chelating agents. I obviously don't have any experience with that because I don't diagnose, or I don't give people chelating agents. However, I've done a lot of research on these topics, and I've experimented a lot with nutrition. And the research shows that the nutrition is actually just as good, actually better, just as good at lowering iron, but actually decreases iron-induced damage better. And the reason is because the nutrients that bind to iron are also really good anti-inflammatory antioxidants. So for example, just to name a couple, I go through a lot in the book, but one of my favorite ones is curcumin, because curcumin is this wonderful anti-inflammatory that binds to iron and can, if taken in a high enough dose, can really dramatically quickly lower iron. That may not be enough for somebody with really high iron, but you can always add other layers. You can also do these type of things in tandem with removing blood if you can remove blood. And then there's multiple other nutrients. I go through them in the book, but like, for example, quercetin. Quercetin decreases iron absorption because it increases this hormone hepcidin, which when hepcidin is high, you absorb less iron. And so people that have hemochromatosis, they don't make as much hepcidin. And so so they absorb more iron. So if you take quercetin, then that will help to lower iron absorption. It doesn't hurt that quercetin is also a wonderful antioxidant, anti-inflammatory, has lots of good properties. And then of course, looking at diet, if you have, because some people, they get diagnosed, like their ferritin's 3,000, they have serious issues, and nobody should ever be allowed to have a ferritin of 3,000. Like that didn't just happen between last year's well visit and this one. They have been mismanaged their entire life. If you have a ferritin of 3,000, those people are almost always the highest risk hemochromatosis patients because they inherited two of the really high risk genes. They're technically called C282Y homozygous patients because the worst hemochromatosis gene is the C282Y gene. And if you inherit two of them, then you have like a very high risk for becoming high in iron. And so it's a very small percent of the population that has that genotype, but they make up a large percent of the diagnosed population because they are like the most obvious people to be diagnosed, because the clinicians are so bad at diagnosing it that it's like, well, we catch them, we catch the really obvious ones, after their ferritin gets to 3,000. And that's really frustrating. The other thing that's really frustrating about that, which is why your question is so important, is that a lot of people that get diagnosed with hemochromatosis, it takes months. A lot of these people, it can take a year before they can get in with a hematologist to get proper treatment, or gastroenterologist or whatever, especially like in the UK, where there's a huge percentage of people that have hereditary hemochromatosis, because this gene, like 60% of Irish people have this gene because it's just genetically, it came from this Celtic Viking ancestor, and it's very prolific in the Northern European Caucasian population. It is spread throughout the world, highest concentrations, Northern European, UK is very high density. And so they also have, their socialized medicine system. And, I'm not saying that it's better or worse than what we have, because we have our problems, but what I have learned from these people is that it certainly can take these people that are now have a really high ferritin, it can take them a long time to get in. And this is a very frustrating experience for them because they're sitting around like, now they know they have this issue, they're miserable, they're feel horrible, and they can't get treatment. And so knowing that you can use specific nutritional supplements to lower iron is another tool in the tool bag. As far as donating blood, the rules are changing. It used to be that if you told somebody you needed to donate blood because you have hereditary hemochromatosis, they wouldn't let you. That is slowly changing. It's kind of weird. If you go to the blood donation center and they, you tell them the doctor told me to donate blood, they're like, oh no, we can't. But if you're just doing it out of the kindness of your heart, then they don't care. And then diet, like the foods, if you really have really high iron, then, you're probably not going to want to eat a lot of red meat and shellfish, really high iron foods, until you get your iron levels down into a healthy managed level. And then everybody's different as far as what they can and can't tolerate. But if you really want to get your iron levels lower, then, don't add fuel to the fire.
Yeah. I just wanted to add a point in. I do agree that when you're that high, you really, really need help, and you need help faster than unfortunately you can get. But I don't want people to wait that long. Like for me, anything in the triple digits, we should
Oh,
start
yeah.
working on now to prevent them from getting high. It's just amazing the number of women that I work with who, yes, the doctor has said, look, you're outside of the range, don't worry about it, and you've seen it go from like 350 to 600 to 800. Like they're waiting for the 1,000 mark to go, oh, we should do something. Why are you waiting for this damage to occur? It's just insane.
Yeah, and in the book, I have research showing that actually 100 should be the cutoff point.
I
Over
agree.
100, there's really no health benefits to it being over 100. And it's, you know, there's after 200, there's a direct correlation with shortness of life. Once the further you get past 200, okay, your life's going to be shorter. 300, shorter life. 400, shorter life. So on and so forth. But you make such a good point, because I keep hearing people say, well, my doctor said I can wait till it's 1,000. I'm like, that's not even like the lab range. The lab range is awful as is, but 1,000 in my mind is just like, or do you just want to wait till somebody's basically in a corpse? The other thing that is a big pet peeve of mine is that I don't know what it's like in Australia, but in America, the lab ranges on iron saturation allow people to go up to 55% before they're out of range high.
Yeah, it's
But
45 here.
okay, so 45 is what it should be. 45 or over with a ferritin, a high ferritin, which in my opinion, a ferritin over 100, it's not just my opinion based on, what I want it to be, based on research, ferritin over 100 plus iron saturation over 45, that's hemochromatosis. So 45, even that's the diagnosis cutoff. Why the labs have that made up 55% number, I don't know. It just allows more and more people to have more and more high iron, and it just makes no sense to me.
Especially when it's something, the sooner you start working on reducing your iron, you're moving further away from chronic disease versus let's just wait until there is damage, there is chronic disease, and then we'll go, oh, this is a problem. It just
Mhm.
makes no sense at all. So I guess summing it all up, putting it together, we would start with saying, guys, this should be a part of your annual testing. If it's not a part of your annual testing, go in there, get it done. If it's concern, if it's borderline, if it's unusual, you're going to need more frequent testing than annually. But if it's normal, annually is probably a good place to start. If it's abnormal, have you checked your genes? Is there potentially a genetic component to this? Which means if it is genetic, it's more likely to be a long term problem that you need help with and that you need to be managed and supported to get on top of this. If it's not a genetic component, doesn't mean that you wash your hands of it and walk away. It means you need to get your iron down, but you can potentially look at diet, lifestyle, nutrients like quercetin that you've mentioned, um, to get on top of it. And you still should check that things are in a better place, but it might not be such a long term issue for you. Um, Moving forward from that, we did talk a little bit about diet, not wanting to add fuel to the fire, maybe not having so much red meat and shellfish. I'm going to add alcohol to that because alcohol also
Mhm.
increases iron absorption. With lifestyle, I don't know whether we touched on it, but I know some of the big ones are smoking and being inactive. Also, if you're cooking with cast iron cookware, that can also be a bit of a concern. So, just having a look at your day to day input because iron can come in through through orally, through digestion. It can come in via the skin, and there are some like skin whitening products and things that may have some iron in there, so that's something to be mindful of. It can also come in through the respiratory system. So checking maybe having an air filter in your house might be a good place to start to reduce that. Have I missed anything?
That's a good summary. I'm not convinced cast iron affects iron levels that much.
Okay.
And I think the reason, there is research that clearly shows that if you cook like spaghetti or a food that is really acidic and cast iron, it does increase the iron concentration in the food, but it's non-heme iron, and non-heme iron is not very absorbable. Whereas heme iron, which is like found in animal products, is much more absorbable. If you're not cooking in cast iron, you just not like you need to start. My concern is I don't want people to like go to cooking with non-stick Teflon type
Oh
stuff.
no.
Like glass, stainless steel, those are good
Ceramic.
options. Yeah. But personally, we're a pretty big cast iron family, and I watch my husband's iron levels pretty closely, and it doesn't seem to be too big of a problem, but it does, everybody's different. And I think what you said is really important. It's all about getting those regular labs. You don't know what you don't know. You could go from being low one year to high the next year. Things can change, somewhat quickly.
So would you test more frequently if it wasn't like if you had a normal result, um, would you test more frequently or would you then wait for signs and symptoms to sort of go, well, you're having joint pain, digestive problems, brain fog?
Yeah, so I would never wait for symptoms. So I would say bare minimum, everybody needs to have a full iron panel and the CBC, complete blood count, full blood count. Um, so, but I also think everybody needs to know if they have the hemochromatosis gene. If you have a hemochromatosis gene, then you need to be watched closely.
Mm.
Maybe for some people that is once a year. Personally, I think it deserves at least twice a year. And then if you have a history of high or low iron, then you probably need to be checked even more often so that you can figure out, is what you're doing to correct your iron levels working, or is it not working? Or, where are you?
Yeah. Really good point. And I want to come back to your book because I have had a look through it. It is such an amazing resource and just the amount of reference. This isn't your opinion. This is fully referenced information. Would you like to tell us a little bit more about your book?
Yeah, so it's I feel like I'm giving birth to a child right now. And I'm having that moment where I don't think I ever want to write another book right now, but maybe I'll change my mind in a couple of years. But um I I it's such an important topic. And this book was really born out of my getting frustrated with what I was seeing, and I was frustrated with diagnosing people with having an iron problem, referring them to the hematologist, telling them go talk to your primary care doctor about this, them getting dismissed and coming back to me and saying it's not a problem, my doctor said it's not a problem. And then, I just am like, no, this can't be happening. This is such an issue. So eventually I just got fed up, and I decided I needed to write about this topic, and it really is my life's work. And I kind of, my first book, which was about genes, this book is kind of like the evolution of that, because I discuss a couple genes, And I discuss like not just the hemochromatosis genes, but also some key genetic combinations. Like if you have the hemochromatosis gene with an Alzheimer's gene, that's a really bad genetic combination that you need to be aware of and troubleshoot and like avoid those genetic landmines, because they are genetic landmines, and part of avoiding them would be keeping your iron levels in a healthy range. So there's so much information, and there is a huge part of the book that is devoted to anemias. I do talk about iron deficient anemia because I just feel like if you're going to write a book about iron, you need to at least have a chapter on iron deficient anemia, because if you're asking people to look at iron labs, they need to know what iron deficient anemia looks like and means and all that. But then also, there's a lot of types of anemias that people can have with high iron. You could have hemolytic anemia, where you have the red blood cells are breaking and you get, low red blood cells, like I was talking about. So there's lots of types of anemias that people need to be aware of, because they can cause high iron, but also because simply having hemochromatosis can increase your risk for these like anemias where you have low red blood cells. And that's a complicated situation that I don't feel like a lot of people are getting properly treated. And then at the end of the book, I have the theironcurse protocols, which is basically a series of steps, diet, lifestyle, nutrition, walk you through the steps of blood removal, those type of things, because I want it to be a resource where people can educate themselves rather than be at the mercy of a clinician that maybe doesn't know as much as you would like them to know. So my goal is for it to help educate clinicians and really like move this diagnosis rate in the right direction, but also to not leave people at the mercy of just the clinicians, really allow them to say, okay, hey, what does this chapter say about what does this lab mean? What does this gene mean? And, have a resource for them to learn more about it and what it means. And also, because personally, I'm really interested in kind of the natural holistic world. What are some natural holistic options that maybe they might not get offered through their general hematologist?
So where can they buy this book if they're interested?
So there's Amazon, it's on pre-sale for the ebooks. The paperback will be available shortly. And then if you go to theironcurse.com, then that is a resource where I have information about the book. And then I also have a workshop, which is basically me orally going through all of the information in the Iron Curse in a series of videos, and question and answers. That's also at theironcurse.com.
Awesome. Look, thank you so much for
Thank
writing the
you.
book, because for me as a practitioner, I learned something. I mentioned before I didn't know about the carrier myth. I was always taught one is a carrier, two is the condition. So thank you. And for me, I'm going to use it as a resource. So as patients are coming through, as we're finding these things, there's only so long that I have face to face with the patient. So it's always lovely if I can say, right, your homework, so go and read this book. So thank you for providing me a book that I can use as a resource and a reference for my patients. So thank you so much
Thank
for your
you.
time. I know it's very late at night there. So I'll let you go off to bed. Thank you again.
Thank you so much. Thank you. Good night.